Thank you, Professor Muir, and good evening, ladies and gentlemen. It is a pleasure to have been asked to come and speak, although a bit daunting given that I am a fairly simple chest consultant, as I'll expand on in due course. But many thanks to the organisers and to Invacare for asking me to come. I do have a couple of disclosures, and the first one is to say that I have received support to attend ERS conferences, and I am actually very grateful for that. Oh, I do apologise. I have received support to attend conferences, particularly the current ERS, and I'm very grateful for that because it gives me the opportunity to get to things that I wouldn't otherwise. So many thanks to Invacare for that. My predominant disclosure is to admit that I am not a health economist. I am a simple clinician. So what I'm going to do is present some health economic data, but from a clinical point of view. And what I'll try and do is outline a background of where we've come from in Scotland and where we are now from a clinical point of view. Now, hopefully this will tell a fairly simple story and give a quite neat take-home message at the end of it. So to do that, I'll tell you a bit about where I'm from, the background of the Scottish NHS oxygen system, the developments which we've embraced as they have appeared, and that's resulted in the service that we have today. And we believe that has offered significant benefits for both our patients and for the clinicians, and perhaps importantly in the current economic climate, has offered quite a significant financial saving, as I'll finish with. I come from Dumfries and Galloway, which is a region of southwest Scotland, which is remote and rural with a small district general hospital. It occupies this corner. It is about 6,500 square kilometres, and it is about 180 kilometres across with a population of 150,000. Now, for those of you who don't know Scotland, if I put that in context, our region is about 3 times the size of Luxembourg and has about 25% of the population. The inevitable consequence is that some of our patients are at quite some distance from their healthcare resources, which has implications for delivery of oxygen services. The original system within Scotland had evolved over a number of years and was a bit of a mix of 2 types of service. On the one hand, there was the formal service through secondary care resources with prescription from hospital respiratory consultants, and in theory meant that patients were optimally assessed and managed before prescription of oxygen. But at the same time, oxygen could be provided from primary care with none of those limitations. So patients, as we've heard, could turn up with breathlessness and be provided oxygen without any real assessment of their underlying diagnosis or management of it, and with a not insignificant cost to the healthcare organisation. If they used a certain number of cylinders, they were then automatically converted to a concentrator on the grounds that that was cost effective, which it certainly was, but perhaps might not be beneficial for the patient. So about 10 years ago, this got us thinking that if we could target the patients who got inappropriate oxygen, we might save some money, which we could then invest into better systems for the patients that really needed supplemental oxygen. Around that time, oxygen conservers appeared. And to me, as a simple clinician, the idea that it stopped the waste of oxygen during expiration seemed a good thing. We might save some gas, we might save some money, and prolong cylinder supply. And courtesy of my colleague Phyllis Murphy, a small study was run in Dumfries and Galloway and showed just that. These small devices added to cylinders gave about a 40% increase in ambulation outside the home, so patients were more active, but at the same time we still managed to reduce the number of cylinders used. And a quick calculation suggested that there were clearly financial benefits from this, and the patients were suggesting it gave them quality of life benefit. So new technology was already helping them, and it potentially had a benefit for us, for the accountants. Shortly afterwards, I should add that we got the Conservers onto the Scottish tariff, but we have to regret that we never got round to writing it up for publication, because shortly afterwards home fill appeared. And here was another new technology which we thought offered significant potential. Here was a way for patients to fill their own cylinders at home. They no longer had to travel a round trip of anything up to 40 or 50 miles to go and collect cylinders, or alternatively, there was no requirement on the NHS to deliver them to their homes, offering some saving. We were lucky in that through, again, Phyllis and through a variety of others, we managed to get the first systems in Scotland to test within Dumfries and Galloway, and had the opportunity to seek some feedback from our patients. They suggested significant improvement in freedom. They felt no longer constrained by the limits of the supply that they had and the number of cylinders that they were requiring, and it boosted their confidence to be more active and get out and about. Less concern about supply, and again there was reduction in transport and fuel costs. And a quick calculation suggested from that small number of patients that we'd probably got a cost saving of about 77%. That was clearly beneficial. And it was around this time that there was national interest in what was happening in Dumfries and Galloway. And that was the driver for a change in the whole service within Scotland. Prior to that point, there was this mix of local and regional services. There was some that was pharmacy driven, some from primary care using conventional pre-filled cylinders that were delivered or the patients had to collect. And we saw the opportunity to develop a much more robust system for the future, which simplified the process, offered the new technologies, and ensured optimum assessment of the patients and prescription of the appropriate systems. Now, it was principally driven by about nearly €3 million deficit in the funding of oxygen services within Scotland. But it was rapidly identified that it was important to have clinicians involved in this to ensure that what we ended up with was a robust system for the future that was patient-centred and gave the best care for the patients. It resulted in this pathway, a single point of entry into a standardised oxygen assessment service. Now, that service was provided by specialist teams who had the access to the equipment and the skills to assess the patients, ensure that the underlying disease process was managed optimally before that assessment about supplemental oxygen, and if oxygen was appropriate, that could then be prescribed as a standardised route, then delivered by a single service provider. Built into that would then be ongoing follow-up. And with further developments, we now have an online oxygen prescription and order system. And in the near future, we will also get feedback about the patient's use of the system that's provided. Because as we've heard, the needs may change as the disease process evolves, their quality of life, their circumstances change. And we need to react to that in order to provide a patient-centred and patient-focused service. This has been done in slightly different ways in different units. Ours is run by a nurse consultant and specialist nursing staff with medical input. In other places it will be run by different teams, predominantly multidisciplinary, but all focused around the patient and ensuring the best supply. The clinician or the prescriber is guided within the system. There is information within the prescription system provided by the service provider to ensure that the optimum system for the patient at that point is provided. And as I say, there will be feedback to ensure that the system is adapted to meet the patient needs. Now that spreads across the whole spectrum of the technology that we currently have available, from those who have relatively few needs for ambulatory oxygen provided just with cylinders, through to home fill systems, and on into liquid oxygen for the high use. We believe this has offered significant benefits, both for us as clinicians and for the patient. We have simplified the service. We've taken out community pharmacy. We've removed the issues around general practice or primary care. They all go through a single point of access. The patients have equity of access to a service which is then patient-focused and centred, with optimum diagnosis and management, and then follow-up. And from the clinician point of view, it is a simplified service, and we've got access to all the range of modalities with electronic prescribing and then feedback. And we have seen cost benefits from this. We took the opportunity following the rollout of the national service to do a further review of the home fill system. We got 450 replies from the 750 patients who were on home fill at that point, with all of them reporting that the service was at least equal to what they had previously. I have to say, in Dumfries and Galloway, we had them knocking on our doors for this system because word spread rapidly from the patients that had it that it was easy to use, it improved their freedom, and it gave them reassurance about their oxygen supply. In this study, 92% said their quality of life had been improved by the new system that they had obtained. And again, there was a nearly 80% reduction in cost calculated against conventional cylinders. As I'd mentioned at the beginning, we're very much clinicians, and I'm a fairly simple clinician, but to me it all made sense. Patients could fill their own systems at home. We didn't have lots of ambulatory cylinders in the system, and therefore there should be a cost saving. But quite reasonably, the Health Facility Scotland that coordinates the system across Scotland wanted a better analysis of the cost savings, given the deficit in funding that was present at the outset. And they involved the Health Economics Unit in York University to do a much more detailed economic analysis of the whole process. They were very keen to look at the whole model, develop a costing across that model, and look at the costs of the previous ambulatory cylinders versus the newer systems that had been installed, and try and calculate the potential cost savings, if there were any, of the developments. Now, I have to say, from my point of view, they seem to have been fairly thorough. We did a quick back of the envelope calculation and said if a patient uses 3 ambulatory cylinders a week, that's roughly €100 a week, or about €5,000 a year, whereas home fill would cost roughly €1,000, so we're looking at a €4,000 saving per patient on home fill. Now, one has to say that the home fill is an add-on to a concentrator which most patients have, so that daily rental cost of around €4 includes the cost of the concentrator, which most of the patients would also have even if they were on ambulatory cylinders. But the team also looked at the costs of masks and tubing and all the other consumables that were involved. They then went on to look at the range of cost savings, and as is shown in this slide, there were cost savings across the spectrum of flows for which home fill would be appropriate. This is the monthly cost per patient, or the monthly saving per patient, and clearly there's a big variability from just under €200 up to in excess of €1,000 a month per patient. There's clearly a big saving to be had from the new technology. They extrapolated these results to the patients that we had on home fill at that time, and there were 921 in Scotland, and they gave an estimated conservative saving of €2 million per year from just 1,000 patients. Now, some of you will have done a quick calculation. I mentioned our back of the envelope suggestion that it might be €4,000 per patient per year, and with 1,000 patients on home fill, that should give us about €4,000. Well, actually, our health economics team said all of this is probably a conservative estimate, and what they calculate is we are probably saving something in the region of €6 million per year from this development. We're clearly paying the deficit of the funding in the NHS system, and we're saving a lot more besides. And that's €6 million from just 1,000 patients. I have a bit of trepidation about quoting these figures, and it's not that I don't think they're accurate. My worry is that I'm sure within the audience we will have a lot of the management from both our service provider Dolby Vivisol and also from Invacare. And when they look at that figure, they may wonder whether they're not charging us enough for these systems. So we might have a debate about that in due course. I have a couple of additional slides. In conclusion, we feel that the national reform of the oxygen system within Scotland has made or produced a single consistent care pathway for our patients, and has offered benefits for both patients and clinicians, and is clearly something that has applicability elsewhere. We've shown significant cost savings, and as I say, the health economists say that the savings they calculate are at the conservative end of the spectrum. But at all realistic levels of ambulatory oxygen use, when compared with conventional ambulatory cylinders, we've clearly got significant savings. And as they emphasise to me on numerous emails, they think this is a conservative figure, and they think the potential savings could be considerably higher. If I may, I'll finish with a couple of final slides. The first is to admit, as I'd said at the beginning, I am a clinician, I'm not a health economist, and I'm very grateful to all the people who have provided all the evidence that I've been talking about. Phyllis has been instrumental in driving the service locally, which was what led to some of the developments in the national service headed up by Willie McGee at Health Facilities Scotland. Joe and Nick at the York Health Economics Consortium have done all these calculations and are very keen to emphasise that they are the conservative end of the cost savings. And thanks to Hugh at Invacare and to Dolby who provide our service, and finally to Invacare who provide the equipment and have organised this symposium. I will finish with one simple take-home message. I will emphasise this is not an Invacare advertising slide. This is something that occurred to us shortly after HomeFill appeared, and we had a rush of patients demanding to get hold of it and actually refusing to give it up when the short trial finished. We discovered that HomeFill clearly is better for our patients, and it's clearly better for our pockets, and the savings are significant from a very simple development. Thank you very much.